Morning to everyone. Welcome to another session on Pediatric CME. Today we have Dr. Jain presenting to us a very common condition that we all encounter as pediatricians, RSV infection, which affects starting from newborns up until old age, but majorly affects babies between 2 months to 2 years, and the morbidity and the mortality associated with this infection. So over to you, Dr. Jain. We'll get started. Thank you.
Uh, Hello, good morning, doctors. Today I will present about the respiratory syncytial virus or RSV. Okay. RSV is a common and highly contagious seasonal virus that infects the nose, throat, and lungs. For most people, it causes mild cold-like symptoms but can be life-threatening for infants and older adults. Typically starts as mild upper respiratory tract infection and progresses to more serious lower respiratory tract infection. Most cases resemble a common cold and resolve within 1 to 2 weeks. The clinical presentation varies significantly based on age and health status. Classification, usually RSV is a human orthohumovirus. It is a negative sense, non-segmented, single-stranded RNA virus. It is enveloped medium-sized virus, which was discovered in 1956, belonging to the family of Pneumoviridae, with the genus Orthopneumovirus, with subgroups A and B. The subgroups, both A and B subgroups co-circulate annually with dominance often shifting between the two every 1 to 2 years. RSV causes a major cause of infant mortality worldwide since it's highly contagious in nature. It is highly prevalent in young children with a peak incidence in 2 to 8 months of age. Most of the children are infected by RSV by the age of 4 years, but almost 90% usually had it in the first 2 years of life. Hospitalizations annually in children under 5 by US statistics. It's the leading cause of bronchiolitis and pneumonia in infants. 2 to 3% of all infants will require hospitalizations. RSV epidemics is seasonal and lasts on average 5 to 6 months, usually starts on winter months. There are high-risk population. Usually, it's the premature infants born less than 37 weeks, infants younger than 6 months, children with chronic lung disease or congenital heart disease, and immunocompromised children. The clinical presentation of RSV, incubation period. Usually, it's contagious during the first week or so after infection. Sometimes it will continue up to 4 weeks. The peak illness typically reaches its worst point between days 3 and 5 after the symptoms start. In normal infants who encounters RSV for the first time at age 6 to 9 months, RSV infection usually causes upper respiratory symptoms. In 25 to 40% of such infections, however, the respiratory tract below the larynx also becomes involved, And the primary manifestations of the lower respiratory tract disease is bronchiolitis and pneumonia. RSV has been reported in various studies as causing 10% of group cases, 5 to 40% of the pneumonia and bronchitis in young children, and 50 to 90% of the cases in bronchiolitis. Clinically, the condition presents as cough, coryza, wheezing, and low-grade fever. The early signs are runny nose or congested nose, sneezing, decreased appetite, mild to dry cough, sore throat, fever. Usually, it's low-grade. Uh, Progression happens wherein the lower respiratory tract it occurs within 1 to 3 days after the onset of rhinorrhea. These are some of the lower respiratory tract symptoms, which tachypnea, retractions, apnea, RSV reinfection with the virus occurs throughout the life. In advancing age, the RSV infection is confined more on the upper respiratory tract than the lower respiratory tract. These are some of the presentations by vulnerable age group. For infants less than 1 year, for premature, usually there's a high risk of apnea. RSV diagnosis is generally based on history, physical examination, and the time of year symptoms occur. Laboratory and imaging tests aren't usually needed but can help confirm the diagnosis of RSV complications or rule out other conditions that may cause similar symptoms. So RSV infection diagnosed by identification of viral antigen by rapid diagnostic test, viral isolation, and serology. The gold standard could be the isolation of virus in cell culture. Blood tests like CBC are sometimes done to check the white cell count or to look for any other viruses, bacteria, and other germs. Chest X-ray is done for lung complications such as pneumonia. Specimens are best obtained by aspiration or gentle washing of nasal or nasopharyngeal secretions or by nasal swab. Transmission is usually by direct person-to-person contact via respiratory droplets or hand-to-mouth contact. RSV can survive 30 minutes or more on unwashed hands and 6 hours on surfaces, toys, keyboards, and others. Complications. Hospitalization occurs due to difficulty of breathing, respiratory distress, and dehydration. Major complications, respiratory failure, which is the most common serious complication, can be seen from RSV. This is due to severe bronchiolitis with fatigue, hypercapnia, or apnea. Sometimes we require an oxygen support with the patient using HFNC or CPAP as the case arise. Apnea is usually in premature infants, age less than 2 to 3 months. It can be a presenting sign even without severe distress. So the management is really to admit the patient with continuous cardiorespiratory monitoring. Dehydration or feeding difficulty, most common reason for admission, especially for less than 6 months old. So we can do by nasogastric tube feeding, or if really there is tachypnea, which is greater than 60 to 70 respiratory rate, we can, and signs of dehydration, we can give IV fluids. But we have to avoid excess fluids due to the risk of hyponatremia. Secondary bacterial infection, acute otitis media is the very common complication of RSV, occurring after day 3 and 5 in 20% of cases. Bacterial pneumonia, uh, which is also a complication of RSV, especially in young infants. Acute respiratory distress syndrome, it is rare but can occur in severe cases, usually occurring in infants with comorbidities or immunocompromised patients. The clues is persistent hypoxia despite the use of CPAP or HFNC. Excuse me. And showing bilateral chest X-ray infiltrates. Management usually in the pedia ICU with the lung protective ventilation, low tidal volume, and higher PEP. Atelectasis, which is due to mucus plugging and small airway collapse. It's common in moderate to severe bronchiolitis. Presenting sign could be worsening hypoxia, decreased breath sounds. It can be managed by suctioning, prone positioning. HFNC and CPAP may help to reopen alveoli. Respiratory failure from hypercapnia is progressively increasing carbon dioxide retention. It can be seen also apneic spells or brew-like episodes, which can occur in even mild disease, especially in young infants. Late or post-illness complications, there is recurrent wheezing or asthma-like symptoms. Many infants with this, severe RSV have repeated wheezing episodes later or post-viral airway hyperactivity. It is highest risk in hospitalized infants or those who are less than 6 months old. Prolonged coughing can happen also, lasting 2 to 4 weeks. Cardiac complications or rare complications that can happen are myocarditis, SIADH, and sepsis-like presentation in neonates. Management and treatment for RSV, the main management is really supportive care only. Most cases are mild and managed at home with fluids and antipyretics. Providing hydration and comfort to the patient, moist air by using cool mist humidifier in child's room, which can ease coughing and make breathing more comfortable. Nasal washing using saline and suctioning. Honey could help in more than 1-year-old babies because it can soothe the throat and help with cough symptom relief. It helps coat the throat. Fever management by giving antipyretics, good hydration, nutrition, and follow-up. Antibiotics are not effective against RSV. Bronchodilators or steroids are not helpful. Hospital management, it is required for severe respiratory distress or dehydration. ABCs should be checked. The airway, suctioning or normal saline drops, breathing with autotherapy and circulation, IV fluids or nasogastric tube feeding. Nebulizations are done with the NSS, which help loosen secretion and improve comfort. But it can temporarily relieve congestion. If we will give nebulization, the dose is 3 to 5 ml of plain NSS or 0.9 sodium chloride as needed for thick secretions or before we do the suctioning. Hypertonic saline, 3%. The use is controversial. It is not used in the ER. It is sometimes used for admitted patients to help mucus clearance, but benefit is small. So if it is used, we give 4 ml of 3% saline every 6 to 8 hours. But we should give it with close monitoring because sometimes it may worsen the bronchospasm. Trial of salbutamol in RSV only if all applies. Like the age is greater than 6 to 12 months. There is a wheezing, personal or family history of asthma, recurrent wheeze, atopy, or eczema, and previous documented response to bronchodilators. So these are hospital treatments, humidified oxygen, IV for hydration, mechanical ventilation if needed. Inhaled form of antiviral medicine, ribavirin for immunocompromised or high-risk patients can be used, but its use is limited because the side effects, because of lack of efficacy. Prevention and strategies for RSV by frequent hand washing, keeping the infants away from people with cold-like symptoms, and avoid exposure to tobacco smoke because it increases the risk of severe infection. Immunization and prophylaxis for RSV. Nirsevimab is a long-acting monoclonal antibody recommended for newborns and infants under 8 months. It is a single dose shot given in the month before or during RSV season. In less than 8 months, baby born on or entering their first RSV season. It's given also to children 8 months to 19-month-old who are at higher risk of severe RSV disease through their second RSV season. Palivizumab, if nirsevimab is not available or a child is not eligible for it. It requires monthly shots given during the RSV season. It is not recommended for healthy children or adults. Maternal vaccine protects newborns during their first few months of life. FDA-approved RSV vaccine called Abirisbo. It's prevent RSV infants from birth through 6 months of age. Single shot is given from 32 weeks to 36 weeks during September through January in the United States. So this is the new immunization guidelines of 2025 to 2026. The CDC recommends 2 primary, one or the other options to protect infants from severe RSV during the first season. So option 1 is the maternal vaccination given to 32 to 36 weeks. Option 2 is the infant monoclonal antibodies using nirsevimab and clesrovimab. So the nirsevimab is a long-acting shot for infants 8 months, as I mentioned. The dose is given by infants based on infants' weights. If less than 5 kg, 50 milligram through IM, and more than 5 kg is 100 milligram through IM. Clesrovimab is a newer long-acting option approved for infants under 8 months. It is a single fixed 105 milligram dose for all eligible infants regardless of weight. It's not recommended for infants entering their second RSV season. So second season protection, nirsevimab recommended for high-risk children 8 to 19 months entering their second season, and those with chronic lung disease of prematurity or severe immune compromise. So When do we seek medical advice? Usually, if we see cyanosis, signs of dehydration for children who have lethargy or poor feeding and high fever. Okay, that's all. Sale.
Thank you, Dr. Jain, for that comprehensive presentation. Any questions anybody has?
Thank you, Dr. Jain, for the good presentation. Yesterday, I saw a child. Actually, this was like lethargic and very much in distress. Now, my question is: does adrenaline has any role in treating this case? This case?
No, no, doctor. Actually, this one is more of like a cleaning, nasal cleaning, and preventing the lower respiratory tract complications. But adrenaline will not help. The recommendation actually is more of a saline nasal washing or cleaning and positioning of the patient, preventing the dehydration also.
See, all these things are done. We started, but some standard texts are telling that. That's why anybody, if he knows, can
No,
give it.
just to interrupt, actually, I had one case, similar RSV, plus had a little bit of croup. So, first initially treated as a croup, so I had given adrenaline, and then it turned out to be a RSV positive. But I think if at all, the presentation wise, if it comes with a croup, I think adrenaline may help. Otherwise, as such, RSV per se, I think it has got no role.
Yeah.
Yeah, I think that can be reserved for severe cases of bronchiolitis, not responding to standard treatment. We have used in the beginning when we had admitted to the preterm baby just after discharge came back with RSV positive. So we had to give, in fact, we gave both salbutamol as well as adrenaline. And the baby responded. So it also depends. See, bronchodilators are not routinely indicated.
Yes.
But if they're not responding and the respiratory distress is severe, you can give them a trial of bronchodilators. And if there is significant response within the first 15, 20 minutes after giving the bronchodilator, then that can be continued. But if there's not much response, there's no point in continuing the bronchodilator. This would also, it'll be important for us also to gather history from the family. If there is a family history of underlying asthma, these babies tend to be more responsive to bronchodilation because there may be an overlap of bronchoconstriction with respect to just bronchiolitis. And then clinically, basically, it is good for us to classify them into severe and non-severe bronchiolitis. Severe bronchiolitis, of course, will require admission, like that 2 to 3% that requires admission. But most of them are non-severe. And there are three clinical criteria that you can use. One is history. If there is no history of vomiting, repeated vomiting, that would be considered non-severe. Second is the state of hydration status. If they're passing urine well, they're having wet diapers at least once every 4 to 6 hours. That's an indication that it's non-severe. And third is about feeding. If they're able to feed nearly normally, that will categorize them as being non-severe. So non-severe bronchiolitis cases can be kept under the radar, ask them to come back for a close follow-up, and then admit as and when they progress to increased to severe symptoms. Whereas if a baby has any of these, is throwing up regularly, is not able to feed well, and of course has decreased urination, then that will necessitate admission, or at least admission in the ER for a few hours and see how the baby settles down, and then decide about actual hospitalization. Yeah. In fact, this year we've seen increasing numbers of newborn babies and less than 1 month coming with RSV symptoms. In fact, they present with just apnea. Sometimes they will not have any other symptom. Just apnea is sufficient, and it's good to get the RSV swab done. Although routinely it is mentioned in textbooks like there's no need to do a nasopharyngeal swab, but it is good for us to have an objective evidence so that you can prognosticate the whole case. Yeah, any other questions?
Similarly, antiviral, because even that is also given in some places. So do we have that, or do you know that is available in Bahrain? Because in India, I think they are giving antiviral ribavirin to in
I
some.
think it must be available in tertiary hospitals. I suppose it's there in, I'm not sure whether it's there in Salmania and KHUH, but so the RSV vaccination is now available. And now RSV is not just a problem of infants and toddlers. RSV can infect across the different age groups. And RSV infection in elderly, immunocompromised adults is going to be even severe. So it is important, especially when in a hospital setting, to kind of separate these cases, infants and pediatrics with RSV, from the general wards that have adults, or place them in different wards. That's exactly what we're doing. But then we have a practical problem in KHAMH, in that we have monitors available, cardiac monitors, and more often than not, these RSVs, unless they are stable, they would require to go on the cardiac monitor. And that's available only in the 3A ward, either there or in the ICU. ICU, anyway, there's no problem because every cubicle is like an isolation room. It is under vacuum. But then this 3A, there will be an intermingling of cases. So that's a challenge. And that the RSV vaccination is now available, I think we will have to advise patients, especially when a baby comes with the RSV infection and there are elderly, say, grandparents there. It is at least best to tell them that this is not so good, to practice infection control at home and separate them as far as possible. Some practical tips that we can give them to prevent infection in the elderly. So any more questions or comments? Yeah, if there are no more comments and questions, we'll close it here. Thank you very much, Dr. Jain.
Welcome, though.
Yeah.